We got it.
All right. All right, well, thanks for having me. So I just was going to use this lecture to talk about how we improve cardiovascular care and outcomes and how we measure and respond to performance measures. It's something I've been spending time thinking about and working on. So kind of we'll discuss some principles and then some of my own recent work. So these are my disclosures. So in terms of the overview, I'm going to be talking about how do we go about developing performance measures, discuss some studies looking at variations and where we know there's gaps in cardiovascular care quality, and then get into methodologic issues and unintended consequences that can come about from using performance measures, and then hopefully an outlook of the future of care improvement. So this is sort of the framework that I see as like the ideal framework for improving care quality. It's driven by the holy grail of our evidence base, which is RCTs. RCTs are great for new interventions and novel ideas because it breaks confounding. It's built on an intention to treat principle. So we get a very good estimate of the effect we would expect if in a similar population. The second step takes time, but in general is becoming a better and better process. We have expert committees, societies, multiple stakeholders engaged to sort of synthesize the evidence for us. And then usually that goes into a guideline. It gets heavily peer reviewed and then released with the goal of seeing implementation of those guideline practices. And then implementation is sort of the last step. We want to do what we have learned. And so now there's a whole field of implementation scientists. How do you go about implementing something well? How do you get people to adopt better practices? How do you get people to change their practices? How do you get better at patient engagement? It's a very messy field, and it's not really clear what's the best way to do things more optimally. When it comes to guideline construction, I've been fortunate to participate in this process. I kind of think of it sort of like a Mad Libs, where the ideal guideline statement says that you identify a clear population and you're recommending some sort of treatment, usually for the prevention or improvement of outcomes that are very specific. So we usually, in a guideline committee, you'll get topic questions of interest, and then at least two authors sort of present some of their ideas of how they want to construct, based on the evidence, what studies are relevant and how they might go about synthesizing that evidence as an evidence-based statement. And then eventually they formulate a draft. It gets feedback from the rest of the committee, and over a year or two process, you get updates to the guidelines regarding what are the new, class 1 and various indicated therapies that we should be encouraging. But within medicine, there's always uncertainty. It's pervasive. You're never going to find the perfect RCT to deal with your clinical situation at any point in time. These are just some examples where uncertainty creeps up. You have patient populations that aren't representative of the trial population that you see regularly who have a certain problem. It may be that you have a related diagnosis that was actually excluded in the trial, but you think that the therapy would still be applicable, even though we sort of may not have evidence. You may only have observational data to sort of make your judgments of whether something would be beneficial or not. Often what we're stuck with in clinical trials and studies is that we've improved some sort of physiologic or surrogate marker. It might be sort of a difference in difference, or it might not even be a randomized design, and whether surrogate markers are a good representation of the outcomes we think we're improving. We've been misled before in certain situations. examples, debates over mechanical support for cardiogenic shock. You have a very sick population, hard to think about randomization designs, but we've been sort of misled before by, things like balloon pump that did not necessarily improve outcomes in certain settings. And there's still sort of uncertainty. You have all these various antiplatelet therapies for post-MI studies, and how do you synthesize them? How do you figure out the ideal time period? And sort of depending on the studies that are fresh in your mind, or your personal preferences, you can sort of fit the literature around what might be an optimal practice, but it can be difficult to answer some of these questions. And then you have things where like you have very old data. So what, we worry about left main disease and triple vessel disease, but most of those studies were done in an era where medical therapies that we currently use weren't utilized. And so true understanding of risk currently can be hard to communicate and measure. So, I focus a lot on heart failure and gaps in care for heart failure. So in the recent consensus guidelines, sort of broken down where we have the cornerstones of therapy being ACE, ARB, and beta blocker. That's the first green blocks. And then thinking about all our add-on therapies as pillars of heart failure management. And then everything in green here is in class 1 indication. We have our aldosterone antagonists with some patient population characteristics to think about in terms of renal function, potassium monitoring, our SGLT2s, reducing mortality, hospitalizations, multiple new studies now indicated for HFpEF as well. Diuretic agents, this is more just for practicality of maintaining euvolemia. And then for African-American patients, hydralazine, isosorbide, et cetera. So we know we have these indicated therapies, they're class 1, and yet there continues to be gaps in, when you look at our patients with a certain condition getting the recommended treatments, we tend to see underutilization. So a lot of this is looking at prescription rates. Are people receiving the therapies we think they should be receiving? And so if you look at hypertension control, you look at whether people are getting statins, all the things I sort of list here are still underutilized from a population standpoint and lead to a lot of preventable cardiovascular events. The use of anticoagulation for AFib, appropriate secondary prevention therapies for patients who have CAD or history of ACS, or heart failure therapies, use of cardiac rehab for heart failure and post-surgery, even basic things like smoking cessation, getting referrals or documentation, large gaps in care. As an example, this is from the Million Hearts project discussing about hypertension in the US. So we have about 47% of the population having hypertension based on the old criteria of a blood pressure of 140 greater than 90. About 21% of those would only be recommended for sort of lifestyle modification only. But 80%, about 91 million people should be getting a medication in addition. When you look at whether people have blood pressure controlled, only about 26% of the population with hypertension does. When you look at who's being treated, who has hypertension, about half of patients are not treated at all. And then when you get down to the millions of Americans who do not have blood pressure well controlled, it's about 40 million. So, basic risk factor identified with very early cohort studies, a number of therapies to help us control blood pressure, newer guidelines encouraging even further risk reduction for higher risk patients to get systolic blood pressures below 130. And yet we really haven't made any progress in improving the receipt of blood pressure control over time in our country. This is from Dr. Fonerow and Get With the Guidelines, from CHAMP Heart Failure Registry. So if we look at heart failure patients, and we look at the rates at which they're getting ACE, ARB, ARNI, beta blocker, and even stratifying whether they have a systolic blood pressure greater than 110 or less than 110, you get large gaps in care. Patients aren't, they tend to be, if they do get the therapy, they tend to be at below target doses. And then when you look at patients who are getting between 50% to 100% of the target doses, you're getting percentages less than, 15, 20%. So when we look at patients who seem to have no exclusion criteria, these patients don't have renal disease, they have documented heart failure, it's based on chart review, still have large gaps in care, and you see similar things in sort of the VA population. So I've been interested, I'm a telecardiology director at GLA and thinking about how can we better reach and access our patients. And so my research question for this project was, I really want to understand what are the regional differences within the VA in terms of the receipt of evidence-based therapies for heart failure. So the VA is the largest integrated healthcare system in the US. It's very unique. Everything is centralized in terms of the data. We have, while each VA may use their own implementation of a very, one of the first electronic health records, CPRS, all that data is centrally organized and stored. And so you can see patients' prescription rates, their fill rates, their hospitalizations within the VA system, outpatient visits, et cetera. And so for this project, I wanted to look at, well, where are our heart failure patients located and what is the quality of the care they're getting on GDMT metrics? So in the total cohort of patients within the VA, there's about 560,000 veterans with a documented heart failure code. So very prevalent. And for this project, we wanted to kind of isolate, who's engaged in VA care and who has recently had an echo that shows that they have a reduced ejection fraction. So the VA, I think about 3 or 4 years ago, created a new variable for LVEF within the system, because if you think about all these healthcare systems, they all use different ecosystems. Ejection fraction is not always a variable coded into separately into an imaging database. And so there was a project around natural language processing to just identify LVEF from echo reports or progress notes and get timestamps for when that study was done. And so there's a hierarchical decision tree just to pull that LVEF variable. So I basically used that and distilled this down to around 200,000 heart failure patients who have an EF less than 40%. And so this map I've been showing you is the density of heart failure patients within each hospital referral region. And so the hospital referral regions are geographic constructs that come out of the Dartmouth Atlas. The Dartmouth group has been, historically one of the places that looked at all this variation in healthcare and trying to improve quality of care based on geographic variation. And so a hospital referral region is something that they define, and they update occasionally every like 4 or 5 years. But it's generally sized to be about 120,000 people, or at a minimum. And it's basically the population patterns for where they would seek care. So, people in Southern California tend to stay in this little area, in LA or whatever, to go for hospital care. And then some of these less populated areas might only have a few hospitals in their region that serve the population. And so that's how those maps are created. And so I use that based on the VA, patient's home address to put them into these regions to see, where is care varying. So yeah, the overall cohort is from July 1st, 2020 to 2021. And then the size is about 180,000. And then depending on the GDMT metric, we exclude them based on renal function, and not a dialysis patient, et cetera. No real contraindications based on lab values, or like if they're hospice or something, we exclude them. And so these bar graphs are just a little hard to read probably, but this is for hospital referral regions, just how much variation there is in terms of the percent receiving ACE, ARB, or ARNI. So the scale here on this first bar graph in the top left goes from 40 to 90%. And for each hospital referral region, there had to have been a minimum of at least 20 heart failure patients to calculate the metric. So some of the tail end performances might be related to small populations, but in general, for the whole country, you see significant variation just on these basic metrics with the wide range. This is for SGLT2s. The high range on the x-axis is about 30%. Beta blockers, much higher rates similar to ACE, ARB, ARNI, GDM performance metrics, and SGLT2s, which are newer therapies, slowly ramping up, but the scale here goes to 20%. And so for this project, I defined success just whether a patient received one prescription in the course of the year. And that's a very common construct for a performance metric, for a health system to see, was there ever one prescription for a class of medications? And then this paper is hopefully about to be submitted, but it kind of creates these maps for each of the GDMT metrics and how are we performing. So all the maps over here on the left side are absolute values, so absolute percentages. So every map here has the same scale, and red is bad and blue purple is good. And so this is the ACE, ARB, ARNI map. It's sort of a green map. Beta blocker use is slightly higher than ACE, ARB, ARNI. And then the red ones are sort of our newer therapies. Just looking at ARNI utilization is very low, and SGLT2 is low, and MRA is slightly better, but still in a very low range in this like yellowish 30 percentile range. And then these maps were an idea I had to look at performance in terms of Z-scores. So, just like bone density, you calculate a Z-score to standardize the variation that you're seeing. You can do this for, exams. Z-scores can tell you if someone's at, 2 standard deviations above performance or below performance. And so it's basically the same information, but now we're grounding it where average performance is going to be in this gray zone. And then if you're an outlier in terms of your performance, you're bluer. But if you're worse in your performance, you're going to be a more yellow region. And so, the main map that we wanted to produce was a composite of across all the heart failure GDMT metrics. Let's create a composite score and look at which regions are doing really well. So surprisingly, like these regions of Texas, which have a lot of heart failure patients, if you look at like the population map, there's a high density of heart failure patients, and they seem to do pretty well in general across all 5 metrics all 4 metrics. I didn't put ARNI and ACE ARNI as overlapping. So anyway, you see areas where there's a lot lower performance or a lot higher performance. And this is sort of a table of trying to condense some of the highlights of that work, where you're looking at, well, what are our current prescription rates for ACE, ARB, ARNI, looking at the median performance based on hospital referral regions. So it's only around 70% of patients. ARNI is very low at 12.2%, beta blocker is 80%. And this is all sort of consistent with the literature. There's still these margins where people aren't performing that well, and it's not clear why. And then if you look at just these huge regions with, populations of at least 120,000 people, in terms of heart failure, there was a range of, somewhere between 20 to like 3,000 patients within these regions. but there's wide variation depending on where you live in terms of performance. And then we sort of highlight some areas that seem to have a very high prescribing rate and lower rates. To me, it's interesting to see that like Santa Barbara stands out because GLA actually provides, we're the cardiologist for Santa Barbara within the VA, unless you're being seen in community care. So a lot of those patients are seen in community care. I don't know, the fellows in my experience, I'm sure you notice sometimes community care isn't the most evidence-based or timely with some of our with titrating GDMT and especially newer therapies. And so it might be that how rural someone is and how accessible they might have like a heart failure clinic, that probably affects the quality of care. Yeah, Vampola, you got to pick up the pace. Comment from Eric. Next, I'll transition to this idea of having a learning health system. So the Agency for Healthcare Research and Quality, their definition of a learning health system is that you're using internal data and experience that are systematically integrated with external evidence and knowledge to put into practice. So as a result, patients get higher quality care, safer, more efficient care. Institute of Medicine in like 2007 put this workshop together and basically a textbook going through principles of learning healthcare systems and how people can sort of develop the structure to start integrating these concepts. And in 2007, they said that by the year 2020, they expected 90% of clinical decisions would be supported by accurate, timely, and up-to-date clinical information. So basically, like 15 years ago, people expected that EHRs would be at the point where you basically have up to date at your fingertips, that the computer would tell you, this patient has this problem and you should think about these therapies and automate sort of the orders and support you. But that really hasn't happened at all. And even basic things like including an ASCVD risk score into Epic, that's a very difficult process because of the data cleaning that goes into it and validation, and something like that just took 2-3 years of work locally to establish. So to do that for all the decisions a clinician has to do, I think it was a bit optimistic in 2007 to put out a statement like that. So anyway, in terms of learning health system, part of learning is getting feedback. So I kind of thinking about categories that we put are, the types of feedback we see in medicine on how we're performing as clinicians or how the system might be performing. So we sort of have the basic assessment of knowledge, but that tends not to really happen too often outside of being a trainee. So you get tested, you have boards, you have MOC type of things, but in general, we don't see that type of, you get cases and you test your knowledge to see if you're still current with the best evidence. Direct observation is a form of feedback. Students and trainees tend to receive that. Faculty get evaluations if they're teaching in an academic setting, but in general, once you're practicing on your own and you're outside of an academic center, you really may not be getting much feedback, and it's sort of up to you to decide what might be valuable in terms of CME credits or whatever you might require to maintain your licensing. Academic centers, hospitals tend to have requirements for M&Ms. You can learn from lawsuits about your colleagues that did something wrong, things in the press, etc. Some of these events trigger sort of like a root cause analysis. You might revisit decision making. What was the information present at the time, and were there errors in judgment? And then thinking about system safeguards as a response to that type of feedback. And then I think the type of thing we're seeing in Medicare type policies and reimbursement policies is integrating performance and quality measures. So some of these things, like, are people getting a certain medication that they should be? Medications tend to be something that's commonly used in a performance measure, or sometimes including outcomes. So these tend to usually be retrospective reports. I remember being a trainee and finding out how many A1Cs in my VA population I had been ordering, whose A1C was very high, and whether, how often they've seen me. But there was really no guidance on what I'm supposed to do with that report as a resident. Like, I sort of manage my patients, but there was no system of response. You can have pay for performance. That's something that our division at UCLA has started to integrate for faculty. Is, you're going to be, for the things that we are saying are class 1 indicated therapies, we're going to start, using the UCLA Population Health Office under Maria Hahn and that infrastructure to create dashboards to actually look at each attending's performance and see how they're doing, and whether we can over time improve the receipt of these therapies. Sometimes you can get focused interventions. If you're seeing some area where quality seems to be poor, focusing resources or having committees to figure out what's going on or what are the reasons. Is this a really accurate statement of quality? And then these performance measures are used, for awards. Get with the guidelines, U.S. News and World Reports. UCLA, in terms of, I feel like their care hasn't changed drastically, but the methods and what U.S. News and World Reports has been using in terms of risk adjustment on quality measures, and they feel like their science is improving in how they construct performance measures. But it's basically when they make updates to the performance measures, things like UCLA becoming number 3 in the nation because we do well on these sort of performance measures, and our population does well, ends up creating a lot of prestige. So it's valuable to the institution for us to do well on performance measures that are being followed. So yeah, how do we create a performance measure? Step 1, you want to identify that evidence-based recommendation, class 1 either therapy or sort of those never events that shouldn't happen, and you want to start counting them or look at the rate at which people are getting it. And the next thing you want to think about is the construct validity. Can we reasonably measure this? Next, and then after that, you want to think about how can you incentivize or encourage improvements in the performance measures. Step 4, I think, is important, is you without accounting for health equity and disparities, you might be disadvantaging people or hurting people by creating a performance measure. There can be adverse consequences to that. And then, the last step is, once you put out a performance measure, you don't abandon it. You need to evaluate what is happening and are there unintended consequences. And then I like this quote from Goodhart's law, that anytime you take something with observed statistical regularity, it will tend to collapse once pressure is placed upon it for control purposes. So the idea is that once you create a performance metric and it becomes something people are motivated to improve that performance measure number, you start getting unintended sort of pressure, and that performance measure might not be as useful as you thought it would be. So in terms of creating an e-measure, some of the challenges that I think often are glossed over or not discussed in detail, and I think this comes up a lot in research, but the fundamental problem that challenges performance measures and research is measurement error. That means that the data that you're generating is poor quality. So, all these, things they teach you in statistics about, is it normally distributed? Is the model appropriate? Fancy models. The fundamental core and our biggest challenge as researchers is, even for implementation, is the quality of the variables we're looking at. If you're creating garbage, unreliable data with a lot of missingness or inaccuracies, you can't build off of that. You can't create models off of that. And so this is one of the major drawbacks of machine learning. Big data, people get all excited about some fancy algorithm doing something that often isn't better than just principled statistical methods. You're putting garbage into an algorithm, and then you start seeing patterns that the model's telling you exist with machine learning, and you haven't fundamentally addressed all the measurement error in your data. And so what are types of measurement errors? So you can have false attribution. This can happen in, if you're looking at EHR data and clinical practice, people can have upcoding practices. There can be incentives for a physician to document something that's, not truly there, or severity, saying something is you spent a lot of time, or you did all that, billing a lot of excessive critical care time, whatever it is. You can have upcoding, you can have billers upcode things. LVEF, this is one of the most challenging things. You would think it's just a number, but it's extremely difficult to get a complete data set that includes just an ejection fraction. It requires data standardization. So we have sort of this HLA7 system, but people, when they created reporting systems, didn't account for, what if someone wanted to really make sure this variable is 100% reliable all the time. And so like the VA has a patchwork solution. They use natural language processing, and that has a lot of drawbacks based on my own experience with it. You can have under ascertainment. That's a common problem in the VA, where we don't code our problems in patients' charts. Patients have heart failure. No one's put in a diagnostic code for years. And so that patient is never included in any type of quality intervention or in studies. You can have omitted variables, where something you care about is not being systematically recorded. Something that comes up for performance metrics is that we don't actually document or code intolerances systematically. Like if someone, maybe the reason 25% of people aren't on an ACE/ARB/ARNI is because they were tried on one and they, were always symptomatically hypotensive with very low doses, or the patient's preference is just they don't want it. There's no field for you to capture that for the medication, and our charting systems aren't designed for capturing these things, but maybe they should if we're going to emphasize things like performance metrics. And then an e-measure can have perverse incentives. Maybe there's financial or pay related incentives for what you're doing or documenting. So one example me and Dr. Foner like to discuss are the unintended consequences of the hospital readmission program. So this was mostly led by the Yale group in terms of helping CMS create policies to improve quality. And the idea was that, why are people being discharged from the hospital and 20% of the time coming back within 30 days? It's a very high rate. Maybe we can reduce that rate if we withhold 3% of all people's Medicare payment, and then risk adjusted, and people who have lower readmission rates will get more money. And so you pay more for something, you're going to get better quality. That was the principle. That's going to work. But what actually happened was like the observation that with this being implemented, that heart failure mortality actually increased, and it's not clear why that might be, but it could be because patients now that come to the hospital with heart failure, if you admit them, you're worried, and they were recently in the hospital, you don't want to admit them, so you're more likely to give them one shot of Lasix in the ED and send them home, and then they go home and they have adverse events. There was a lot of, the easiest way to reduce your readmission risk wasn't to do any, increased social work or increased nursing ratios. That stuff is all expensive. The best way to reduce your readmission rate is to improve your risk score. So if you document the patients who have diabetes better, more CKD, the more you document comorbidities, the lower your risk adjusted hospitalization rate is. So while you created a policy to improve care, you might have just employed more coders to better improve your metric. And then these studies showed that you actually created worsening disparities, because the hospitals that always got penalized were the hospitals that served low-income patients in low-income regions that were already under-resourced. So how is a hospital who's struggling with readmissions supposed to get better if the financial incentive is for them, or the financial consequences of them losing money? Is heart failure care going to get better when you take money away from a low-resourced hospital? And so CMS finally responded to all these criticisms and harm by stratifying hospitals' performance based on how many Medicaid patients they have. So before there was no adjustment, and the policy led to worsening outcomes. And now they're trying to say that we're going to try to control for low-income hospitals and let them compete against each other in this model. So in terms of, why we use these performance and quality measures, so it's helpful for research and policies. We can get descriptive analyses out of it. We can use them for pragmatic trials, and then we can try to sometimes think about causal inference and observational methods with using these performance metrics. They're used for quality improvement, so types of feedback. You sort of have quality improvement models where you kind of have feedback systems, and this is what's used in industry, like the Toyota way, where you have some system of looking at data, sort of the learning health system principles, but Six Sigma, lean, reducing waste, different types of formalized root cause analyses, and then implementation science. So, people in health services are trying to identify how to improve uptake of practices, or what the issues are that are leading to challenges. So yeah, when we go back to that original framework, I think, we have RCTs, we have our guidelines, but performance measures give us some sort of wider lens to understand how we're doing, and hopefully will guide us towards better implementation. And I believe, and I think Dr. Fonarow believes, that we shouldn't focus on outcomes, because people can game, if it's something like risk adjustment, they can game trying to show that their outcomes are better. But if you're going to create a metric, it should be tied to the process. Like if you want people to give more SGLT2s to heart failure patients, then incentivize that. Don't incentivize hospitalizations, because it's very vague and not helpful to create a performance metric around an outcome. So when we look at our heart failure, this is hypertension performance measure in the guidelines. So, in terms of ACC/AHA, we have clinical guideline committees that put out the recommendations, and then there's an actual performance measure committee, and they sort of set up what the structure of a recommended performance measure should be. So this is for hypertension, our numerator is going to be how many patients do we have a blood pressure less than 130. For patients aged between 18 to 85, who have stage 2 hypertension, and at least one outpatient encounter and a diagnosis during the first 6 months of the year. We're going to exclude people with end-stage renal disease, kidney transplant, pregnancy, etc. So they put in some exclusion. It's a measure that's going to last 12 months, and then you can use your EHR, etc. And so this is to monitor how are you doing in terms of managing hypertension in your healthcare clinic or system. This is sort of the recommended metric structure that we think people should try to implement. And then, this is a heart failure metric. So this is for people with an LVEF less than 40%, where they prescribed a beta blocker. There's exclusions if they had a heart transplant LVAD. So this is how the guidelines sort of set up their definitions. But just transitioning, so often this leads to more alerts in the EHR system. So you want to improve beta blocker usage, and your solution is to create a pop-up screen that says, why isn't this patient on a beta blocker? And people just ignore it, X out of it, or don't respond to it. Looking at some of the literature that burnout in EHRs, people feel burnt out because they're spending excessive time on the EHR. The workflows often aren't optimized for clinicians for, they tend to capture a lot of billing data accurately, but they're not really optimized for you to deliver care optimally. Looking at just the average time people spend per day on EHRs, documentation is like 84% of the time, order entry 12% of the time, doing chart review of medications and notes. So yeah, it becomes difficult when people decide that you want to improve a performance measure and add something else in. And if everyone's trying to add in their little pet care quality issue, it can be, a very poor experience for both clinicians or primary care, et cetera. This is something about just alert fatigue. The more alerts you create, the less responsive people become. If you're, I know CPRS always gives me the same, stupid alerts about, patient is on like ACE/ARB and you're adding in spironolactone, is that safe? I tend to just ignore even other alerts because I'm so inundated with alerts that aren't helpful. So if you start adding more measures, it'll start hurting other measures. So, AHA/ACC tries to be mindful of this, that we try to retire old measures with very high performance. So, getting an echo for inpatients with heart failure, it had a very high success rate. It didn't seem like something that should continuously be emphasized, so that was retired. Giving an aspirin for MI, at this point, you have to be kind of brain dead to not think about aspirin if you're treating ACS. So things like that get retired. In residency, when I first got exposed to research, my closest mentor was Leora Horowitz. She's now director of the Center of Healthcare Innovation and Delivery Science at NYU. She's done really great work. This was like pre-pandemic, and during COVID, they produced some of the largest, data studies about, what patients were coming in with, complications, their risk and outcomes for COVID patients. But this was her New England Journal paper with very limited funding. She had like a $1 million seed grant, and they designed basically 10 randomized trials, most of them centered around the EHR and quality improvement, and to look at, could they improve processes of care? So most of these are built around alerts, but it's basically A/B testing. And this is sort of what big tech companies, web companies do to us all the time. They test one way of, the Twitter algorithm to see how engaged you are versus a different way of the algorithm and see which one increases how often you use Twitter. And if intervention B works better, they're going to go with that. And so they're constantly A/B testing. And this paper Leora did was basically that same idea is, well, we want people to improve their influenza vaccination rates. So let's test something where the nurses get different styles of prompts about reminders. And unfortunately, I think the first one they didn't randomize nurses, they randomized patients. And so nurses were exposed to both interventions. So that one didn't work out. But for smoking cessation, they looked at different types of practice alerts and see what they could do. And this was that if the smoking cessation alert said that it was a billable service, that led to clinicians ordering it more. And so that wording was more helpful. Looking at care gaps, like who wasn't doing their colonoscopies, et cetera, they found that doing a mail reminder versus no reminder made no difference. So they saved the health system money by not doing mailed reminders. So it's a very cool study just because it's very practical and shows that how important randomization is to assessing, are we achieving what we think we're achieving? And I think from a healthcare administration type of thing, we want to generate this type of evidence to see, are we achieving what we think we're doing with our intervention? Going to transition. I added this slide because unfortunately, Paul Farmer passed away, was it last week, suddenly from possibly cardiac causes in Rwanda. And I was sort of reading up on the old New Yorker piece about him, and I remember reading Mountains Beyond Mountains in med school, and he's sort of one of the gold standards for moral integrity in medicine. But this was from the New Yorker piece, and it was a favorite Dr. Paul story from Haiti in the village of Cape Hen was that at the time, many years earlier, when he chased a man into a field of cane, calling him plaintively to come out and be treated, he still went after patients occasionally to inspire the staff, he said. hence the trip to Moore Michael. So the reporter's with him and she's taking him to go like hunt down a patient to figure out how they can make sure he's taking his HIV meds or his TB meds, et cetera. But something Paul Farmer really, I think, emphasized in his writings and teachings and his, how he practiced medicine was that non-adherence, this term non-adherence and non-compliance was never a deficiency of a patient. It was society and medicine's failure to deliver the care that they sort of deserved. And so I have this other quote. I'll just read a few paragraphs because I think it highlights some of his ideas. So this was from an article he wrote called "Investigating the Root Causes of Global Health Crisis," and he uses an example of a primary care physician at Brigham and Women's that he respected. So just let me, yeah. So this is a quote. "I will add that Heidi Beferuz is another hero of mine, a primary care doctor at Brigham and Women's Hospital and a true partner in health in every sense of the term. Heidi and her team have spent years providing care for patients struggling in the shadow of Boston's teaching hospitals, not only with AIDS, but with other chronic medical conditions, but against poverty and its attendant social disarray. Some are homeless or almost, many are jobless or work in dead-end jobs with few benefits. Many don't speak English or speak it poorly. Few have good health insurance. Some are illegal aliens, surely one of the most bizarre labels we've cooked up. And some have other problems with the law. Some are elderly and frail. Most have more than one affliction. In the eyes of most of our colleagues, however, these particular patients were failing medical therapy for AIDS, which was revolutionized by some by the advent about 20 years ago of effective therapy. But in Dr. Beferuz's view, medical therapy was failing them, even though most were and are eligible for such therapy through publicly funded programs. They were not adhering to the treatment nor enjoying ready access to many other social services. Was the primary problem the non-compliant patients, or were there upstream problems from housing instability to running afoul of the law and the other synergy of plagues that ran together in their lives, limiting their ability to comply, keep appointments, fill prescriptions, and all the other things we ask of patients? How much of the problem was due to fractured and inconvenient systems of care? Were the upstream problems really beyond the reach of a coalition of concerned providers? For many of these patients, we learned the problem was delivery. Dr. Beferuz had shown that by providing regular care and social services with the help of community health workers, as in Haiti and Peru, we could expect patients who are failing or being failed to do much better than those receiving standard care, which is delivered primarily in clinics and at the time of the provider's choosing. This is true whether the outcomes followed clinical ones. Regarding AIDS, this would include CD4 counts, viral loads, opportunistic infections, such as mortality, or markers of health system utilization. For example, emergency room visits or failure to fill prescriptions or show up for appointments. Dr. Beferuz's team has also shown that the cost of providing good community-based care is less than providing hospital-based care with little in the way of follow-up at home, the standard of care that emerged in the US over the course of the previous century. So, I think that kind of gets to what I like to think about in terms of we do a good job of taking care of patients we see, but we often don't think about a population of patients we're responsible for and reaching the patients that are truly difficult, that are at much higher risk for hospitalization, et cetera. So this leads me, let's see how much time do I have. So, what this leads me to sort of what we know works for improving cardiovascular care quality. So if you reduce barriers to care, so if you can make access to outpatient care more convenient, if you can reduce outpatient costs, these are the types of things Paul Farmer emphasized, was having, medications should be free, there shouldn't be, you didn't bill patients in these deprived areas. He went about trying to find funding from external sources to support the care he wanted to deliver. Team-based care, so a lot of interventions around including pharmacists in our clinics, taking a team-based approach to improving care quality, our APRNs, social workers, case managers that help extend the ability to provide care. And so this is getting into sort of things I'm doing at the VA. The VA has academic detailing is our group of informatics pharmacists. They're pharmacists who have coding experience basically, and they create these performance measures for various diseases that they think are sensitive to better quality care. And so it was about 2 years ago, they created one for heart failure. You can look at who's been discharged in the last 14 days and whether they have a follow-up appointment in the next 14 days. So, and it creates an actionable list. You can click on this number 9 and see who are these 9 patients who don't have an appointment after having just been in the hospital for heart failure. You can see who's getting visits in the last year, and then we have sort of our ACE/ARB/ARNI beta blocker, et cetera. And then it creates actionable lists. So my interest was like, well, we have this dashboard, but no one's told us how to use it. And I wanted to figure out how do you structure, someone's time or some intervention to basically improve care on these metrics. So do dashboards work? Well, there's really no RCT evidence to claim that a dashboard helps you improve cardiovascular care. There's no understanding of how do you properly implement something like dashboard or population health for workflows. It was an opportunity to me to think about A/B testing. And then we have new therapies like SGLT2s and ARNIs where we want to kind of do more rapid implementation. And I was curious if I could do that more quickly than sort of our current process of patients show up as scheduled and you look for opportunities when they're in your clinic. So with one of the residents who was an intern when she approached me, she said she wanted to do a clinical project, and I sort of had this idea, but she really has taken the lead and motivated me to do a randomized study. So we decided to register and get approval for a pragmatic randomized controlled trial. We took 300 patients off of the dashboard who looked like they were getting poor quality care, and we wanted to randomize them to just usual VA care, wait for them to filter through, or let's compare that to like a proactive panel management clinic. And our idea was to have a half-day clinic where you basically get a list from the dashboard of these heart failure patients who seem to be getting poor care, and then you work at your own pace for the 4.5 hours. And you can go as fast or as slow as you want, but the goal is for you to sort of go through the chart, review the patients, and see if you can identify areas where you can improve their care. And then we basically cold called patients, and we weren't sure like how often does a patient who doesn't expect a physician to call them to pick up the phone. It turned out to be pretty high. I think I haven't calculated it yet, but I think it's somewhere between 60–70% of patients would pick up the phone. And then even if we couldn't reach the patient, we left a chart review note in the chart for the primary care physicians to see. We would co-sign them. We tried to think about different ways to sort of nudge people towards better care. We would mail letters to the patients and hopefully hope that it would get the gears moving and improving their heart failure care. So we've done the intervention and we're just waiting for our outcomes. But in September of 2021, we identified, there's 4,000 patients on our local dashboard. We set a criteria for like the quality of care for heart failure using GDMT points. Basically, there's an optimization score, and the lowest points were the ones we focused on. So patients with a score of less than 5 were randomized. We're at 300, and we did simple randomization. There was no consent, nothing. As usual care or the intervention, and we completed it in 21 clinics in about 2.5 months. And now the results will be pragmatically assessed in June of 2022. And this is just some of our baseline characteristics. Median age 71. We only had 2 females, but they were in each arm, but they were perfectly randomized, so balanced. 38% of our patients are African American. And then, 5% had 1 admission in the last year. And then these are our optimization scores. And then this is the framework we came up with for how do we score GDMT for across all measures. So if you're not getting any medication, it's 0 points. If you're at least getting a medication, you get 1 point for ACE/ARB/ARNI, beta blocker, MRA, or ARNI. Since there's no titration of SGLT2s, you get 2 points for getting an SGLT2. And then you get 2 points if you get a target dose of ACE/ARB/ARNI, beta blocker, MRA, et cetera. So the questions for our study are, did we more efficiently optimize care after 6 months compared to our usual care arm? And that's looking at the difference in optimization scores from baseline and the other 6 months. We also want to estimate how much clinical time we were taking per patient. And then what type of reasons did we identify for the gaps in cares that, maybe the performance measure wasn't accurately capturing. All right, just go to so what do I think about the future of cardiovascular care improvement? I think it's important to think about how we create platforms to assess quality of care assessment, and then think about building pragmatic RCTs off of that. I think A/B testing things and knowing what's working, sort of the things that UCLA Health is starting to do with their population health office would be really important. And then thinking about, engaging with clinicians about helping offload their workflow. So, if you're going to test things, you really have to engage people on, how are they currently working and what are the things that aren't helpful or what would be more useful so that they don't get burnout, et cetera, from inappropriate prompts or et cetera. Maybe we can help them streamline, the care that they're already providing. And then I think it's important to be proactive about care quality. I think the idea of just looking at data from a few years ago, retrospective reporting of quality isn't helpful, that we need to integrate feedback systems sort of with this learning healthcare principle of responding to areas where we see gaps, and then always monitoring for unintended consequences. All right, so I talked for a long time, but happy to take questions from anyone. See, so what?
Boback, that was great. One question, how important do you think financial incentives are around the quality improvement efforts, pay for performance, or is this really out of the goodness of clinicians' hearts to do right by their patients?
Yeah, so the literature says that payment for most of these incentive programs tends to not have much of an effect. It's very modest at best. And I think some of these studies, they've looked at like larger scale studies in the UK with how incentivizing various primary care things, performance measures doesn't cost too much of a boost. I think it does, it's almost like it probably serves more of a marketing tool where it may raise these metrics to people's consciousness more. And eventually we might, if we talk about it enough, at least it becomes to the forefront of people's mind. And so they're really going to think about GDMT more carefully, say, when the next time they see a heart failure patient. But I think we've sort of lacked that evidence of, how effective is the payment? And either for systems or single providers, it doesn't seem like payment makes too much of a difference regarding this, especially when it tends to usually be like some small sliver. And I don't know if increasing that really makes sense. If it's going to be 5–10% of your income, whether it's health system or clinician, I don't know if people don't really know how to respond to that incentive. But yeah, I don't know how the current program is going. Yet for within our division, do we have a sense for how are people feeling about it? And is it making a difference?
That data will be forthcoming and interesting to see.
Yeah.
This is Alberta. Great work with the dashboard. One of the challenges we've had, like just trying to do EHR extraction, is really identifying or how we document when something has been tried, other than adding it to the allergy list. Let's say they got profound hypertension with an excuse me, with an attempt at low dose Tresto, so in terms of trying to benchmark how we're performing and either not getting to these target doses. It's great you're extracting the blood pressure, because we do know that often providers perceive low blood pressure, but I'm talking about profound things like hypotension. I'm always in a struggle whether to add it to the adverse reactions until I've given it more time to reintroduce.
Yeah, I mean, I think the problem is it's not routinely used. So I think even within like the VA system, you don't have to. Even though it shows up on the allergy tab, it gives you an intolerance option. But often it's like it'll be free text maybe. It's not very clear. People don't really write it clearly, and so when you want to. I haven't seen anyone use it in terms of their exclusions for performance metrics, because that variable just tends to be so bad and underutilized. But I think if we're going to move towards, say, we care a lot about heart failure, and we want to know, we want to have a reliable metric that accounts for intolerance, then we probably have to create a data field that goes along with the prompts. That's sort of like, your patient has heart failure. This is a reminder to think about adding this therapy. And then to get rid of that prompt, you sort of have to put in what the reason is that, was it patient preference, or was it a true intolerance or something that was written in the note? But I think we sort of have to figure out how to capture that data better.
Yeah. And I heard you mention that we don't, well, that we don't put in diagnosis codes, but we are supposed to, every time there's an encounter, you are supposed to put in a diagnosis code and a procedure code for each encounter, whether it's a phone call or face-to-face. So unfortunately, our ICD-10 coding is sometimes a little laborious, the search tool, and I find that providers often pick not appropriate diagnosis codes, but it is required.
Yeah, it's required, but I know on the VA side, I think we're somewhere between 20 to 30% undercoding. So it affects, even though it doesn't affect our personal billing or salaries, to the health system, we lose a lot of money because our VA specifically doesn't code very well, and the VAs that have a lot of billers that can code comorbidities, and they have to be kept active. So if someone doesn't check CKD in the last 2 years, then that falls off as no longer an active problem for some reason. And so that, when the risk adjustment reimbursement comes in, it's not actually captured. But yeah, we're not trained as coders and billers, and it's kind of annoying to have to do it, but it affects data quality if these things aren't put in accurately. Other comments?
This is Mohammed Majid here. That was great lecture. Thank you so much. I learned a lot from it. It looks like I completely agree that once the patient is not up to the performance measure, it's a failure of the medical community that we haven't reached out to the patient. And we really need to use the behavioral models, to change the behavior both on part of the doctor and the patients. I was part of a clinical trial group. We used a smartphone app-based education to increase the vaccination rate in people with cardiac disease. I can't go into detail. It's on the review in one of our medical journals, but essentially now that every patient has a smartphone, I think that's a venue that we haven't used enough to send them education and nudges and reminders to get them up to the performance measures. I hope this is something that we can use more in the other areas of medications for the patients.
This is something our UCLA health system is sort of a little bit of a vanguard in. With the COVID vaccines, they ran a randomized study of with the Anderson School of Medicine, some of the faculty there of the types of messages you give to patients. So something within UCLA Health is that we have Care Connect and MyChart, but patient engagement is actually kind of low with MyChart. Most people are annoyed to have to like set it up or log in or use it. You have to be pretty educated and tech savvy to care about that. But the intervention for COVID vaccines was based around text messaging. So just in culture, a lot of people like getting text messages as long as it's not too invasive. And so figuring out how to do non-intrusive messaging that's positive and might nudge people in the right way. And so they did a study showing that, if you say things like, we have your appointment booked for your vaccine, that led to higher uptake that was, that was reasonable, that this simple intervention could improve vaccine uptake. And so that was published in Nature from our UCLA group, doing the variation and different messaging. And so they're like open to things like text messages, but the problem is they don't want to overload patients. So they're very sensitive to, if we're going to test something, it has to be high value and sort of align with our goals and make sure that it's, acceptable among like primary care, et cetera. But those types of interventions tend to be, a growing area to understand of, can we use self-management apps or different forms of messaging to improve patient engagement. All right, well, thanks for everyone for listening, and feel free to ask me questions after the talk.
Thank you.
Thanks so much.
Good job,
All
Robin.
right.